Thank you everyone for joining tonight for the OTAC Clinical Case webinar on the updated long-acting injectable buprenorphine guidance. We have the first author of the guidance with us today, Professor Nick Lintzeris, who is also a staff specialist at the Drug and Alcohol Services in Southeast Sydney Local Health District and is part of the Specialty of Addiction Medicine at the University of Sydney. So I'd like to begin by acknowledging the traditional custodians of the country on lands on which we meet and recognize their continuing connection to land, waters, and culture. I'd also like to pay our respects to their elders past, present, and emerging. So this is just about the registrations for tonight. We have a very even mix of regional and metropolitan participants tonight with some interstate, including Tasmania, South Australia, and Victoria. Good representation. And also the breakdown of the specialties and roles. A lot of general practitioners as usual and pharmacists, but also a lot from other nursing roles and other health professionals. And thank you to everyone for joining tonight. And just a little bit about the OTAC Clinical Case webinars. If this is your first time here, these are monthly webinars that we typically hold on Tuesday nights, just an hour long with some cases. And if you come to the live session, we will send out an email certificate for CPD points that you can use to redeem. And the webinar will also be recorded and made available on the OTAC website. So please be mindful if you're making any comments. And also feel free to put your questions in the chat. We have Dr. Sharon Reed who's joining us tonight to monitor the chat. And I'll turn it over to Nick.
Okay, so this is very much an update on the new long-acting injectable buprenorphine guidelines. First and foremost, just want to talk about the terminology. By now, you would have seen that different people are referring to these medications in different ways. In New South Wales, our first guidelines came out and we called them depot buprenorphine. The consensus for this document is that we're calling them the long-acting injectable buprenorphine, or LAIB, but you will see that there's other abbreviations get used from time to time. Okay, the background. So we first started using these depot products in 2017, 16, 17 was the first time in Australia that we got our hands on them. This was in various clinical trials before registration. And that was where we got a lot of our early exposure on how to use the medications. What it meant that by the time that the medications were being registered at the end of 2019, at the beginning of 2020, so Buvidal came out just a few months before Sublocade. Fortunately, both of them were available for when COVID hit us, so that was good. But it meant that because we had that clinical experience, we were able to publish the first set of guidance documents, came out in 2019. Since then, a lot has happened. There's a lot more depot products have been used. There's been some updates in product labels. There's been some new data, some new evidence, a lot more clinical experience. So it led us to identify the need to update those guidelines, because the first set of guidelines, it has to be said, they were written with minimal clinical experience. I think, you know, we'd had about 100 patients on a depot product in Australia up until then. And no one else, no other country had published guidelines. So it's not like we could plagiarize other people's work. And so the first set of guidelines was our first attempt. What's happened with the depot products? Basically, we've ended up now where we estimate that there are more patients on long-acting depot buprenorphine products than there are sublingual buprenorphine. And you can see the rise there of the depot and the sort of gradual reduction in sublingual bute. The panel on the right there gives you a sense of what medications are actually being used across Australia. So Buvidal, most of it is Buvidal monthly, and you can see there that the most common sort of products are the higher doses, the 128, and then you've got the 96 and the 160s. The weekly products seem to be really sort of transitional as patients are moving sort of, you know, starting treatment and then moving on to the monthlies. With Sublocade, we've got slightly over half of all the doses being used are the 300 milligram doses. That's the higher dose. As we all know, there's 2 dose strengths with the Sublocade. This graph's got a little bit more information. On the left, you can see the tide that has happened over a longer period of time in terms of the changes in sublingual and depot, but also methadone is the big green colour there. What we've now seen is that really for the first time, the last maybe 12 months, we have ended up with more buprenorphine patients than there are methadone patients. That's probably the first time that across Australia that's happened. So methadone's just under 50%, buprenorphine total is just over 50%, and the depot is the most common form of the buprenorphine. On the right, you can see some of the different products that are being used. You can see in New South Wales and ACT, Buvidal is by far the predominant formulation, with much smaller proportions of Sublocade. That varies by jurisdiction. Victoria probably has got the highest Sublocade ratio. Now, this data is from about a year and a half ago, and it may well have shifted since then. I think more and more people are starting to use more Sublocade as well. So, you know, the imbalance, which is more or less about 90-95%, was Buvidal. I think Sublocade market share has probably increased a little bit. Okay. So what are the key updates in these new guidelines? There's been some legislative and regulatory changes. There's a big section on consumer engagement, which I won't cover here, but I do urge everyone to read the section. Some changes on how we commence depot buprenorphine, especially for the Buvidal products, and I'll walk us through those. There's some guidance on how we swap between Buvidal and Sublocade, because that's becoming sort of a more common process that clients are needing to swap between them. We'll also touch on some of the data we've got about what it's like to come off depot buprenorphine, and then we'll talk about a couple of special populations like pregnancy and pain patients. So again, I'll just quickly walk through each of these changes and then hopefully get to the cases. So the legislative and regulatory changes. So the PBS changes, I'm sure all of us are familiar with what's happened there. So since over a year now that the medication has been supported through the PBS S100 system, and this has been a huge impact on patient payments. So a marked reduction in the burden for our clients, which is great. One of the things that's happened, though, is that since the 1st of July of this year, it is no longer possible for anyone to administer a depot product without it having been dispensed by a pharmacy. So what I'm referring to there is some of the medical practices had set up an arrangement where they would get products sent directly from the wholesaler and that they would administer the depot products in the clinics. So the patient would rock up, the doctor would have the depot in there, usually in their safe, not dispensed, and they could choose whichever dose they wanted for the patient there and then. Since the 1st of July, you can't do that if you want PBS reimbursement. So that basically means what's happening now is doctors have to have the doses dispensed at a pharmacy, and that medication needs to get to the medical practice. It'd be interesting to see if there's time, if that's sort of changed practices for any of the GP practices out there. Safe scripts also come in play for New South Wales audiences. Obviously, depot is one of the medications on Safe Script. The other thing that's happened with the New South Wales Safe Script system is that now we can process all our permits through Safe Script, and I think that's been overwhelmingly positive feedback from most of the prescribers. But again, it'd be good to see what people are saying about that. And we've also had some product label changes. All the product label changes have been incorporated into the new guidelines. Okay. Probably the biggest change is what's happened with how we initiate treatment. And the big mover here is Buvidal treatment. When we first wrote the first set of guidelines, whilst we said in there that you can start directly onto Buvidal, there wasn't a lot of experience around that, and the product label for Buvidal still said you must start going via sublingual. So I think a lot of doctors just got into the habit of starting everyone on a sublingual buprenorphine, and then once they stabilise on a dose after 3 days, 5 days, 10 days, something like that, then swap over to a depot, to the Buvidal. In the new guidelines, we actually recommend direct induction onto Buvidal, that you don't need to go via sublingual doses. Now, if a patient wants to initiate via sublingual, sure. The other areas that we think where it probably makes sense to start in sublingual, see what the response is to the buprenorphine before you go onto a depot. So that might be, say, a patient with significant liver disease. So buprenorphine rarely can exacerbate acute liver problems, acute liver disease. So if you've got a patient with liver disease, it probably makes sense, initiate them on sublingual, see if there's any problems with the buprenorphine, if there's a worsening in the hepatic disease. If there's not, then you can go over to the depot. You can see you don't probably want to, load someone up with a depot product to then find out that they've had a complication. Same thing happens with drug-drug interactions. If you've got a patient who's using other medications that may interact clinically with buprenorphine, again, it's easier just to start the patient on sublingual, titrate your doses accordingly, and when you're confident about what's going on with the DDI, then you can swap over. The other group of patients where we say is for those patients who have never, ever been exposed to buprenorphine before. They've never had it, either prescribed or, got some from a mate once. The issue there is some patients get side effects to buprenorphine that they really don't like. And the most common ones is, probably would be severe nausea. Some people get severe headaches. They're probably the most two common ones. And if a patient's never had buprenorphine before and they sort of can say, yeah, no, I'm all right, I don't get bad side effects. If they've never had buprenorphine, you probably want to test them with a sublingual dose, make sure that they're not having problems with the buprenorphine, and then proceed to the depot. If they really don't like buprenorphine because of the side effects, then it tells you, well, let's, stick on the sublingual, see if the side effects settle down, because they usually do. And then you can revisit the decision. Okay, so they're the circumstances where you might think you might want to go via sublingual. Why are we proposing direct induction onto a Buvidal weekly for a heroin user or someone swapping from a short-acting prescription opioid? So a couple of reasons, well, 3 reasons. One, the product label now allows direct induction so that we're all medically covered. The second issue, and I'll spend a little bit of time on this in the next slide, is that there is much lower risk of precipitated withdrawal when you initiate buprenorphine treatment with Buvidal rather than sublingual buprenorphine. So that means we don't have to be waiting for the patient to be in early opiate withdrawal before we dose them with sublingual. So with the Buvidal, as long as the patient is not, intoxicated, you can generally initiate Buvidal. You do not have to wait for precipitated withdrawal. And we'll talk about that in the next slide. The most obvious reason why go straight to Buvidal is because it's just so much more convenient for patients and clinicians. For the patient, it only means they, turn up, get 1 dose, and then maybe be seen 5-7 days later. So that's, again, the convenience starts on day 1. And for clinicians, we don't have to, initiate a patient on the sublingual, organize the scripts, get them to the pharmacy, then review them, then stop the scripts and get new scripts written and so forth. So much easier and more convenient for everyone. All right, precipitated withdrawal.
Nick, we had a question in the chat.
Yeah.
Robin asked, a lot of people find Buvidal very effective for their methamphetamine addiction too. What are your thoughts on this?
So it's not indicated for that. There's no evidence that treating amphetamine dependence with opioids works. So it's not to say that some patients may find it, but I think we need to unpack that a lot more. I think there's a lot of issues going on there. If you have someone who's opioid dependent also using methamphetamines, the stability afforded to them by being on buprenorphine allows them to start both at a psychosocial level and probably also some of the physiological levels, just to start sort of dealing with their cravings and their substance use more effectively. So opioid treatment, methadone and buprenorphine treatment, we know that over time, patients tend to reduce their use of alcohol, their use of benzos, their use of amphetamines, their use of cocaine. So most substances tend to reduce with opioid dependence treatment. Cannabis is probably the one exception to that, but that's another story. So I don't think we can be recommending depot buprenorphine for someone who is not opioid dependent, that is not on label, and it is not supported by the PBS. So if you want to do that, fine, but don't write a PBS script, otherwise you'll be done for Medicare fraud. Okay, moving along. This issue around precipitated withdrawal, why do we say it's less with the depots and Buvidal in particular? So in the graph there, you can see what happens to the plasma concentrations after a dose of sublingual buprenorphine, that's the light grey, and the Buvidal weekly is in the dark. You can see after a dose of sublingual buprenorphine, you get peak effects usually within about 60 minutes to 90 minutes, peak plasma and clinical effects. With the Buvidal, you're not actually hitting your peak really to about hours 16 to 24, although most of it's achieved by 10 to 12 hours. So think about what precipitated withdrawal is all about. Precipitated withdrawal is about the displacement of an opioid, be it heroin or methadone, from an opiate receptor with that first dose of buprenorphine. Remember, buprenorphine's got much higher affinity for the receptor. So if you've got an opiate receptor there and there's a heroin molecule on the receptor, along comes buprenorphine and it will displace it. It will knock it off the receptor and will do the same thing to methadone. But buprenorphine is not as strong an agonist, so it doesn't trigger the opiate receptor to the same extent. So what you get is a rapid displacement of a full agonist like heroin or methadone, which is firing the opiate receptor a lot, and in its place you get a weaker opiate, buprenorphine. And that rapid reduction in opiate activity can be experienced as withdrawal symptoms. And because we precipitated it, we precipitated the withdrawal by that first dose of buprenorphine, that's why we call it precipitated withdrawal. So you're more likely to get precipitated withdrawal with the more rapid onset of buprenorphine, higher doses, because you're displacing more heroin. So that's why when we normally start buprenorphine, often what we do is we start with little doses, sublingual that is. We start with a little dose, 2 milligrams or 4 milligrams. We call it a test dose sometimes. That's like giving them a little bit, make sure it's not going to throw them into precipitated withdrawal. Then we top up a little bit and a little bit more and a little bit more. So that's what we normally do with sublingual. You can see with depot though, you're not getting that rapid displacement because it's a very gradual onset of the buprenorphine over many hours. So if you're a heroin user, imagine if you've just used heroin 1 hour before turning up for your first Buvidal injection. By the time the Buvidal's kicking in about 10, 12 hours, that heroin is no longer active. So it's extremely unlikely that we're going to cause precipitated withdrawal in someone that's been using heroin, which means we don't need to be waiting and telling the patient, well, you know, you only used heroin 3 hours ago or 6 hours ago, you're going to have to come back tomorrow or come back this afternoon. Or, you know, sometimes saying to patients, well, you're not in enough withdrawal just yet, so come back this afternoon. And we know what would happen. Some patients would come back that afternoon, but a lot just didn't and failed to engage in treatment. So basically now what we say is don't delay that first dose of Buvidal. You don't have to wait for the patient to be in significant withdrawal, as we normally do with sublingual. We really say, look, you defer that first dose if the patient is intoxicated or there's other reasons why you're concerned about the patient. It might be their mental state, maybe their cognition, maybe they're sedated, for whatever, you know. So if you've got just clinical concerns about the patient, sure, I wouldn't give them an opiate. Otherwise, you can see that the Buvidal induction pathway is much, much easier. And why we also now generally say, avoid a test dose of buprenorphine. All you're doing is creating the conditions for precipitated withdrawal by that rapid onset of buprenorphine.
Can I just ask a question, Nick?
Yeah.
So I actually saw a patient in clinic, I think last week or the week before, that seemed to have precipitated withdrawal related to being given Buvidal the day before, started off on a 16 milligram dose by another clinician. And she was showing objective signs of withdrawal. And, but she denied, you know, she hadn't used any methadone for a good couple of days, and she denied any other.
That's it. It's a methadone.
Yeah, it's
look,
the
bottom
methadone.
line is, talking to so many clinicians that have been prescribing buprenorphine for 20, 30 years.
Yeah.
Most of us have, can count the number of precipitated withdrawals in a heroin user on one hand.
So that's what we suspected. It was probably the methadone, even though she denied it, and it had been at least a good couple of days. I can't remember exactly, but that's what we presumed. So
most likely.
Yeah,
If
and that's the other thing. Yeah, while you're talking, I don't know if you've got time, the management of precipitated withdrawal.
Well, we know what to do with sublingual. If you precipitate withdrawal with sublingual, you've got a couple of pathways. You've got 3 pathways. One, try to smother the symptoms with symptomatic medication. Our experience is that doesn't tend to work that well. You know, you try to give them some Maxilon or some ondansetron, and you give them some, you know, non-steroidals, and you give them some Buscopan, and none of it really works, as we all know. You know, the real precipitated withdrawal is severe. Like, patients are not comfortable. They're miserable. And, you know, a bit of Brufen and some Maxilon doesn't really deal with that. Your second pathway is hit them with more buprenorphine. So basically, you've got to push on through. Most patients won't accept that. They'll say, you got to be kidding. It's the buprenorphine that made me sick. Bugger off. And, you know, I'm not having any more of that stuff. But if you have a patient that's prepared to accept it, start running the buprenorphine in much bigger doses, like, you know, give them 8 milligrams, another 30 minutes later, another 8 milligrams, you know, or you've got to probably get them up to 24, 32 milligrams quickly.
Oh, okay.
And so that's basically what you're doing there, is you've got to flood your opiate receptors with buprenorphine.
Yeah. I think with this woman, we just did 8 and 8.
Yeah? How'd it go?
She didn't respond very well.
Yeah. You probably got to go faster.
She was slow to
and
respond.
Yeah.
And we ended up taking her to ED, I think, because she was vomiting and needed fluids.
Yeah. Almost certainly, probably, if you've got a really sick patient, they probably need to go to hospital, and that's where you need to rescue them with opiate agonist doses. You just got to rescue them with morphine, really. How do we know that works? Because that's what all the patients used to get precipitated withdrawal, run out of our clinic screaming, go get their drug dealer to get them some heroin. They'd inject some heroin and they'd then come back, say, yeah, poof, that fixed it. So it was actually learning from our early patients' experiences that big doses of an opiate agonist will also relieve precipitated withdrawal. But with depot, again, the option of rescuing them with more buprenorphine, well, if you're going to do that, you've probably got to run in sublingual, lots of it. And I don't know what would work with the full agonist on top of the buprenorphine, probably, but, you're going to be making it up as you go along, so you'd probably want to be in an inpatient hospital setting, really. And what I mean by making it up as you go along is basically, what I mean by that is titrate your doses clinically. So you give a dose, you wait, is the patient better? Do I need to give more? That basically, and you probably need to be using parenteral doses, not oral doses, because you want to rescue the patient. All right. Anyway, that's a nice little distraction about treating precipitated withdrawal. All righty. Sublocade, not much has changed other than previously the Sublocade product label said you had to be on sublingual for at least 7 days of at least 8 milligrams. The product label now basically allows 7 days of buprenorphine treatment, which could be a Buvidal weekly dose. So you can think of Sublocade as also being, you don't have to go via sublingual. You can via sublingual onto the Sublocade monthly, or you could use a dose of Buvidal weekly and then go to the monthly product. So with both Buvidal monthly and Sublocade, which is only monthly, we're basically saying you either start with sublingual or you start with a weekly depot. Okay. All right, so that's induction for heroin users or people using prescription opioids. The other thing that now we're starting to see much more of is people needing to swap between medications. Either they're traveling or they're going to a facility that only does Sublocade or only does Buvidal or whatever. So now we've created some sort of guides there about how to do those sort of dose conversions. And this is partly coming from clinical experience, but also partly coming from some of the pharmacokinetics. So we know what the plasma levels of these different products do. Okay, so that's in your guidelines. I won't spend more time talking about that. Transferring patients from methadone to the depot products. The guidelines walk through 4 different options. I need to emphasize the top 2 options are what we call the conventional approaches. The bottom 2 options are what we would call unconventional, still somewhat a little bit experimental, somewhat a little bit off-label. And we generally would suggest if you're going to do option 3 or option 4, generally talk to a specialist or someone with more experience than you about doing this. So option 1 is a good old-fashioned, the way we used to swap anyone from methadone to sublingual, which generally is bring them down as far as you can, stop the methadone, wait for the patient to go into opiate withdrawal, which can often be 2, 3 days, 4 days. Once they're in significant opiate withdrawal, then you start sublingual doses, small little doses, trickling it up. This tends to work okay for most patients, but for patients on really high doses, it's problematic. And it is fiddly. It takes up time to do all this. And for some patients, they may be on, say, 90 milligrams of methadone, and they don't want to wait 6 months to get down to 40 milligrams, So for some patients, that option 1 isn't kind of ideal for them. Option 2 is something which I would recommend anyone that's looking to transfer a patient from low-dose methadone and they want to go over to a depot. we can now talk about direct transfers, and I'll tell you how to do that. Option 3 is what we call the bridging model or the bridging method. And this is pretty simple and straightforward in its logic. We know that the problem with methadone and precipitated withdrawal is because it's so long-acting. So with the bridging model, what you do is you stop the methadone, swap them over to a short-acting opiate, prescription opiate like morphine or oxycodone, stabilize them on that for 2-3 days. Then you stop the morphine, oxycodone, and initiate buprenorphine treatment as you normally would, as though you're initiating a heroin user or a morphine patient. So that's what we call the bridging method. Probably most widely used in inpatient hospital settings, where we do this quite often. It's been pretty commonly done in hospitals for a long time. The fourth approach is what we call the microdose transfer approach. This is an unusual approach which basically involves, whilst patients are still taking their methadone, you start introducing really low doses of buprenorphine, sublingual buprenorphine. And by really low doses, it'll be day 1, like 0.2 milligrams twice a day. Day 2, up to 0.4 milligrams twice a day. Day 3, 1 milligram twice a day. Day 4, 2 milligrams twice a day, that kind of thing. So it's a gradual incremental increase whilst the patient is still taking their methadone. Then once you get up to a decent dose of sublingual buprenorphine, like around 8 milligrams a day, then you stop the methadone and then ramp up the buprenorphine quickly. This also is fiddly, time-consuming, not easy to do in a community setting. Can be done, but it is fiddly. And again, we generally recommend go talk to a specialist treatment team. If you haven't done these and you're interested in doing it, get some specialist support. And then the model option 2, which we are recommending, is really simple, straightforward. So when you've got a patient on a low dose of methadone, 30 milligrams or less, this is really easy to swap over to Buvidal. Basically, you stop the methadone, you wait until the patient is in early withdrawal, like something like a COWS score of 6, which is a mild withdrawal. This often takes 2 days, 3 days after the last methadone dose. As soon as the patient is starting to think, oh yeah, I'm starting to get a little bit uncomfortable, then you just go in with a Buvidal 16 milligram weekly dose. No test doses, no sublingual test doses. Just go straight in with a Buvidal weekly, and then you follow them up on subsequent days. How are you going? They often might need top-up doses of more Buvidal, and that's where you can top them up with 8 milligram doses every 24 hours if required. So now more and more services have been doing this, and it works pretty well. Not seeing any precipitated withdrawal. And again, you can just see it's so much easier than the sublingual approach of having to start with really multiple small doses, dispensed multiple times a day and so forth. Okay, let's move on. Almost finished.
Could I just ask a question?
Yeah.
So when you're giving the 16 of Buvidal, when does it start to upset the opioid receptors with the methadone?
When you say upset, if you're going to see precipitated withdrawal, if you're going to see it, you would imagine that would happen at a time of peak buprenorphine effects or substantial buprenorphine effects. So you'd probably be seeing it somewhere around 8, 10, 12 hours later.
Okay. So substantial within about 8 hours after.
Sorry?
So you'd say about after 8 hours after the 16 of Buvidal is when.
That's when when logically it could start happening. You need to start seeing, significant buprenorphine plasma levels.
Yeah.
Because the Buvidal weekly, it takes a few hours to start getting absorbed.
Mm-hmm.
Yeah.
Okay, thanks.
All right. Just want to give us a bit of an update. There's some data from a study that's been done at WHO's in Roselle. you know, this is the OSTAR program, OST to abstinence. What we did is we went and got a number of patients on Buvidal monthly, and they were basically an inpatient in the Resi Rehab there, and we basically just monitored them for 16 weeks after their last dose of a 64 milligram Buvidal monthly dose. And basically what we saw was, you can see there, they're the withdrawal scores, the COW score, the objective opiate withdrawal score, the subjective opiate withdrawal score, and also what the cravings. Basically what you can see is very mild, minimal withdrawal experienced, like hardly anything. And that it tended to peak around weeks 6 to 10 after the last Buvidal dose. So that's all really encouraging. It's telling us that, again, it makes perfect sense. With the Buvidal, you stop the dose and it's slowly leaching away from, you know, plasma levels are gradually diminishing over time. So it's like we're doing a slow dose taper internally, if that makes sense. So it looks like we've got a good approach now to helping patients coming off buprenorphine using a depot. But I just want to caution everyone. Look at what happened to the craving scores. You can see that over time, the cravings started to increase over time. The withdrawal scores were not increasing, but the craving was. And I just really want us to all, you know, just to reiterate that even though we've got a medication now that will probably be associated with a mild opiate withdrawal syndrome, dependence is a chronic relapsing remitting condition. Many patients are going to relapse. And so just because we've got an easy sort of medication now, it doesn't mean that patients don't need support. So if patients are looking to come off, we've got to make sure that we're engaging them with psychosocial supports, 12-step programs or smart recovery programs, you know, self-help approaches, peer support, counselling, wherever possible, try to sort of, you know, have some, organise some follow-up with patients, you know, a month, 2 months after the last injection. Okay, and then a couple of final points. Pain management. Basically, we're comfortable now that with acute pain management of the patient on depot, basically you can't stop the depot. The depot's there. You've got to manage the pain with either additional opioids, so give them doses of oxycodone or morphine or whatever the anaesthetist wants to use, and non-opioid approaches as well, other medications, physical therapies, and so forth. With chronic pain, we're treating more and more patients who have chronic pain and opioid dependence with buprenorphine. We've been doing that with sublingual buprenorphine for many years. And we're starting to see we can also get some good outcomes with the depot products as well. Our experience is some patients really like managing their sublingual medications. They like to have, you know, they cut up their films into 4 little bits and they take it out spaced over the course of the day. And, you know, they're really focused on their medication. We're sort of finding those patients don't do well in the depot. You know, for them, the medication handling is part of their issue. And that loss of control over, you know, that idea of I've got pain, I better take a pill. You don't do that with depot. So some patients don't like that. But for other patients, it's really effective. Disconnecting that idea of you might, you know, have low mood, you may have a bit of pain, you may have stress going on in your life. The response should not be reaching for a pill, reaching for a dose of Suboxone. So you can see that depot's got some good psychological kind of aspects to pain management as well.
Nick, there's a question in the chat.
Yeah.
What about codeine use? Is that okay with buprenorphine?
If it's opioid use disorder, absolutely. We used to treat a lot of codeine with sublingual buprenorphine, especially when they took it, when they stopped the over-the-counter supplies. There was a big influx then. I mean, we don't see that many codeine people anymore simply because it's not as available as an over-the-counter medication, so we're just not seeing it as much. But again, folks, just think about it. Buprenorphine is buprenorphine. If sublingual is going to work, then the depot is going to work as well. It's just a different formulation. It's just a different way of getting into the patient. Yeah. Okay. Pregnancy, breastfeeding. Look, the first set of guidelines in 2019, we just didn't have much data or experience, so we're pretty cautious. Now there's much more exposure, especially in the US, where they've been running some trials, some clinical trials with Buvidal and pregnancy, and those all look pretty good. So now we're basically saying, look, that the depot is comparable to the sublingual. It's not necessarily a precaution. We always would recommend that with every patient, you discuss with patients the benefits of being on a sublingual or being on a depot, and the decision that they may want to make. And document those decisions in medical records. Some of the early writing about the depot formulations, you would have heard that, there's these preservatives in the depots. There are, but the concentration of the preservatives in both Sublocade and Buvidal is so low that it's not really clinically meaningful or relevant. So we're not really worried about some of those preservatives. Okay.
There's a question in the chat.
Yeah.
Sorry, Nick.
Yeah, that's what I was going to say. Shall we just pause, ask some questions, then we can maybe go to the case scenario? Or they don't want us to run too over time. Yeah. Oh, yeah. We've got 15 minutes.
So Chloe's written, our local custodial facility routinely does direct induction onto Buvidal monthly 64. Can you comment on this practice?
So if they're going from sublingual to Buvidal, yeah, that's fine. That's what you're supposed to do. If it's sublingual buprenorphine, you can go straight to a monthly product, be it Buvidal monthly or Sublocade. But we don't recommend initiating buprenorphine with a monthly depot. So, but if you're coming off from methadone, you should go via the weekly product. If you're going from heroin or morphine, via the weekly product. But if you're swapping from sublingual bute, yeah. That's absolutely fine.
And there was one more question about any role of buprenorphine patch in opioid dependence.
So, look, the issues with buprenorphine patches is they're really low doses of buprenorphine. So, even if you double patch, you're probably only getting like 1 or 2 milligrams of buprenorphine equivalent sublingual into your system. So the question there is, how effective is 1 or 2 milligrams of sublingual buprenorphine in treating opioid use disorder? Most of our clinical experience and most of our research would tell us that buprenorphine doesn't work very well at those really low doses. Having said that, could you use something like some, the topical patches if you want to do a microdose transfer? Some people are doing that, but that's, again, sort of experimental treatment. I wouldn't be recommending it to a mainstream audience. It's still kind of people still playing around trying to figure out how that works. The other thing you need to appreciate, folks, is that the topical buprenorphine products are not indicated, nor are they on the PBS for treating opioid dependence. So please, 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 please do not ignore those things. It's not subsidized on the PBS for off-label. So if the patient does not have pain, then you should not be using topical patches like Norspan or Temgesic to treat someone's opiate dependence. It's off-label and it's not subsidized by PBS, and PBS could come after you, the doctor, for Medicare fraud if you do it. unless you write as a private script and the patient then has to pay for it. Very few patients are willing to pay for buprenorphine. It's really expensive. Like the average sublingual dose is about $10 to $15 a day. The average Buvidal injection is about $300 a month.
Nick, there's another question in the chat.
Yep.
Missed doses. Could you please comment on missed Buvidal doses, which are beyond 14-day for weekly and I think 7 weeks for monthly? Say if patient has had 1 to 2 weekly doses, missed 20 days since the last weekly dose, has not been using illegal opioids, not in withdrawal, does not want sublingual reinduction. Could you please comment on the safety of reinduction straight to Buvidal in this scenario? It's quite a long question. You might want to have a look at it in the chat.
I'd have to stop sharing and all that kind of stuff.
Oh, okay. Do you want me to read it again? You got it?
Yeah, more or less. So again, if the person says, look, I haven't had any opioids for over a month, I haven't used any heroin, I haven't used any buprenorphine, no methadone, no oxy, no nothing. So can we objectively assess that? Yeah, we do a urine test, don't we? And if you've got access to point of care urine tests, you can actually assess that there and then. Yeah. So the patient says, I haven't used anything. All right, good. If they haven't used anything and there's no evidence of any opiate withdrawal, the question is, so why do you want to be going, why? Why do you want to go back into Buvidal treatment? You know, I wouldn't say no to it, but the question would be, why? And under those circumstances, I 100% get, well, I don't want to be going on sublingual with daily dosing and stuff. I get that. But there's an example. That's the kind of scenario where I'd be saying, yeah, look, yeah, you should be good to go with the Buvidal, but you know what? Maybe you're not good to go. You know, I could accidentally overdose here. So what I want to do is give you a test dose of a sublingual, 4 milligrams, get that into you, wait an hour or two, and, you know, if you haven't turned into liquid on the floor, you know, if you're not sedated and you're coped with that fine, then sure, we can proceed to Buvidal treatment. So, look, at the end of the day, you have to use your clinical judgment, and if something goes wrong, it is absolutely no defense. The coroner won't take it lightly to say, oh, yeah, I know I was cutting some corners. I know I didn't do a proper assessment, but the patient was, you know, didn't want this, didn't want that, didn't want that. And so I ended up doing something risky in order to meet my patient's wishes. But unfortunately, the patient then died. Do you see it doesn't go well when, you know, so safety first, stick to your guns, be confident with your decision-making. If the patient is asking you to do something you're not comfortable with, get a second opinion. That's where things like DASIS can be really useful. You can talk to a specialist on the phone within a matter of minutes, run the case past them, and get some advice there and then.
One more question.
Okay.
Getting tight for time.
All right. But I'm just conscious also the cases would be good to talk about.
Yeah. Any suggestions for increasing buy-in for chronic pain population to start buprenorphine when they have been on their favoured other pain meds for decades and aren't aiming for complete abstinence? So increasing buy-in for chronic pain population to start buprenorphine.
Yeah. Again, remember, folks, we can only use high-dose buprenorphine if you make a diagnosis that the patient is dependent to opioids. Suboxone, Buvidal, and Sublocade are not licensed or indicated for the treatment of pain. They are licensed and indicated and subsidized for the treatment of opioid dependence. So if you have a patient who has pain and dependence, then you can use Suboxone, Buvidal and Sublocade. So you've got to be confident with the diagnosis. And then the biggest issue, you then need to say to the patient, now, this medication should work, but it's licensed in this country for the treatment of opiate addiction. Because if you don't say that to the patient, it's only a matter of time before they find that out somewhere or other. And then, you know, you've basically labeled them a drug addict without having had that conversation. So they need to understand the diagnostic issues. So if you want to use Suboxone or Buvidal or Sublocade, it means you are landing squarely on a diagnosis of pain and addiction. The patient needs to be comfortable with that.
Okay, Nick, so you've got about 6 minutes for your case scenario.
I reckon we should do the case scenarios, yeah?
Yeah,
Right.
yeah. Questions have
Okay.
dried up for the moment. Yep.
Good. So this is a straightforward one. Barry, 33-year-old labourer, 10-year history of on again, off again heroin dependence. Recently, he's been injecting 2 or 3 times a day. He's done a couple of detoxes. He's been on methadone for 6 months in the past and had a couple of years on Suboxone, did pretty well on it. This time around, though, he's recently had a child a few months ago, and he's basically got to get his act together. He's got now, you know, young family to support. So he started full-time work a few weeks ago, but, you know, he can't keep a habit and work going, so he's now come back to treatment. He's labouring, so he's travelling all over to Sydney. It's contract work. He doesn't know where he's going to be from one week to the next. And he got those really early starts. So getting to a chemist early in the morning isn't really a great option for him. And he's just started treatment, so you're not really thrilled about giving him, you know, weekly takeaways in his first week of treatment. On presentation, he last used heroin 3 hours ago. On your assessment, he's not intoxicated. He's not in withdrawal. He looks pretty okay. He asks about starting treatment. He says, you know, there's a bit of a problem about getting to a chemist every day with my work at the moment. How would you approach treatment? I mean, this is a bit of a Dorothy Dix one, isn't it? Because of time, I might just talk us through this one. Here's a good example. Not really suitable in the first week of treatment for getting bucket loads of takeaway doses, can't get to a chemist easily. You can just see how the depot, you know, and this would probably mean starting on a Buvidal weekly would make sense for a patient like this. And indeed, that's what happened. He got dosed with a dose of 16 milligrams weekly. He got his first dose on the Tuesday. You get a phone call from him on Thursday. It's Barry, and he's saying, it's not holding me. Like last night, I was sweating. It's not holding me. You know, I'm thinking about using. It's not working. Can I go back to Suboxone? I knew that worked. How would you respond to Barry? I can't see hands going up. So Sharon, you might just need to call things out.
Top up, Elena says.
Yeah. Patient education is the key thing here. The dose will hold. It's just about probably going to need more doses. Swapping back to Suboxone, it's all the reasons why it wasn't going to be a great option in the first place. So this is a lot of reassurance to the patient. Yep, it will hold. Hang in there. The stuff works better and better. You know, you will be comfortable. You know, within a matter of days. Okay, so that's a pretty straightforward one, and this one is a direct to Buvidal induction.
And so you just top them up with an 8 milligram?
Yeah. Top up is 8 milligram injection. So you can do that every 24 hours, believe it or not, up to a maximum of 40 milligrams in that first week. So technically you could go 16, then 8 the next day, 8 the next day, and 8 the next day after that. I don't think anyone's ever had to do it, but it's an option.
So a maximum dose of, what'd you say?
You can end up with a total of 40 milligrams in that first week.
Including the baseline one?
Yeah, including the baseline.
Yeah.
Yeah. Generally, what I would do, though, with Barry, what I would probably do is top him up on the on the Thursday, which is Tuesday, day 1, Wednesday, day 2, Thursday's day 3. Yeah, top him up. And then basically I'd be telling him, come in on Monday next week and we'll give you your next dose early. You don't have to wait 7 days.
Mm-hmm.
Yeah?
Mm-hmm.
Okay. The next case is Mohammed. He wants to get off. He's been on methadone for the last 3 years. He's done pretty well. He's now on 50 milligrams. He was on 70 milligrams, but over the last 3 months, he has been trickling it down uneventfully, no issues, no major comorbidities, hasn't used for a while. He's married. He's got 2 kids. He's works in his brother's business. He's doing well. He's basically gotten to the point where he kind of wants to get off the program. You know, going to the chemist is a hassle. And ultimately, he's also looking at doing some travel with his family in sometime in the next 6 months or so. He's heard from mates that have been on the depot and had come off it, that it's easier to get off than the methadone. How would you respond to Mohammed? What would be your options? I think this is my last slide, isn't it? Oh no, it's not. Sorry. Yeah. What could you do here? Sharon, I can't see.
Yeah, so no suggestions in the chat at the moment. Any ideas, everyone?
The couple of options, because of time, I'll just rattle them off. One, he could just continue to do gradual reductions on methadone. Yeah. You'll probably take him, I use a rule of thumb, 1 month for every 10 milligrams you're on. So it'll probably take him about 5 months to get off. And that might be okay for him. He might be happy with that. As for the depot, what I'd be explaining to him, yep, it probably, our early experience tells us that people's withdrawal from the depot is milder than stopping methadone. But the challenge for you, Mo, is that you've got to get onto the depot. And we generally, it's hard when patients are on higher doses of methadone, like 50 milligrams or more. Generally, what we would recommend is, if you can, bring your dose down to a lower dose. And if you can get down to 30 milligrams, then we can go direct onto the Buvidal. And that's indeed what Mohammed attempted. I mean, you could talk to this patient about going via sublingual or doing a microdose transfer and all those things. The reason why I think for this patient, just getting them down to a low dose of methadone and then swapping over to the Buvidal kind of makes sense, because one, he's on the way, he's reducing his dose, he's coping, it's uneventful, he's not high risk, he's the kind of patient that can probably continue to trickle the dose of methadone down, getting to a lowish dose that you can then do the simple transfer to Buvidal. And that's what happened. 6 weeks later, he's now down to 35 milligrams and he's ready to transfer. What you do is you organise a last dose of methadone, 30 milligrams as a takeaway dose for the Sunday, and tell him, have it early in the morning on the Sunday. And he has an appointment to see you Monday afternoon. He comes in Monday afternoon. He says, look, I don't really think I've got much withdrawal at the moment. Like, I didn't sleep well last night. He tells you that he's taken Monday and Tuesday off work, but he's got to be back at work on Wednesday. So he kind of wants to get this over and done with. So it's Monday afternoon. He's come back. He had his last dose of 30 milligrams, 9 a.m. on the Sunday morning. It's now 3 o'clock in the afternoon. Who would rush him with a dose of Buvidal now? And who would do the alternative and say, you're not quite there yet, come back tomorrow morning and we'll start your Buvidal then?
Elena suggests come back tomorrow plus symptomatic management. And Sharon also suggests wait.
Yep, so you could definitely wait. The advantage of waiting if you gave this patient Buvidal and the really low risk that something goes wrong, it's going to be going wrong somewhere like 3 o'clock in the morning, 12 hours after the Buvidal dose, because that's when you get your peak effects. So it's probably better to be, first dose early in the morning, so that if something is going wrong, it's happening in the afternoon, evening, not at 3 in the morning, if that makes sense. I agree there could be a role for some symptomatic medications in case the patient's, not coping well. Most of it's placebo, though, really, you can give them some Maxolon or some non-steroidals. I personally don't like giving patient benzos in these circumstances, especially when you want to load them up with opioids the next day. And if you're giving them something like Valium, you don't know, is the sedation that they're experiencing because of the Valium yesterday? So when I'm doing dose titrations, I try to not involve too many other medications that just confuse your clinical assessment. And yeah, that's it.